Hello, my name is Jamie Buchanan. I'm an orthopaedic surgeon at the Spire Sussex Hospital. I was appointed as a consultant in 1998 and my area of special interest is shoulder and elbow conditions. I've become very used to operating using the arthroscope, known as keyhole surgery. This allows access to parts of joints which are difficult to get at when you open the skin in the normal fashion. As a result of this, it makes it much easier to make repairs and take away extra bits of bone which are perhaps getting in the way without causing too much damage to the surrounding muscles. The shoulder joint is prone to many problems, some of which, particularly in the younger individuals, are more sporting or overuse injuries. As we get a bit more senior, about my sort of age, then you start to have problems with degeneration, particularly around the rotator cuff. This is the small group of muscles which helps keep the ball centred in what is a rather small and flat socket which the shoulder anatomy is made of. At times it's possible to get some overgrowth of bone which impinges or rubs on the top surface of the rotator cuff, and this can cause pain lying on that side, reaching overhead, reaching behind your back. If the usual non-operative managements don't work with this, then shaving off this protuberance of bone using the telescope and a small burr can actually be very beneficial in reducing the pain long term. One of the joys of arthroscopic or keyhole surgery is that recovery is normally much quicker than when muscles have been split and skin has been opened. The procedure is done under a general anaesthetic, and despite this, with the adjunct of a local anaesthetic block done at the same time, it means the patient wakes up pain-free and can normally go home the same day. I try very hard not to ask the patient to wear a sling unless it's absolutely necessary, as I think it's absolutely key to get the joint moving and mobilising in the normal way as soon as possible. Depending on the type of surgery which has been performed, the questions of when you can get back to driving, get back to work, get back to sport are the obvious questions to be asked of the surgeon. With a straightforward decompression where some bone has been removed, most people are driving a car at about 10 days and are back at work doing desk tasks reasonably comfortably at around 3 to 4 weeks. More strenuous activities with repeated overhead movements take a few weeks longer. If there's been reconstructive surgery with repair of tendon or stabilisation of a joint which has been dislocating, then rest in a sling for 3 or 4 weeks before beginning the rehab process is usual. If you've had a joint replacement, then though I'd get it moving very quickly, using it for heavy and repeated manual tasks can often be 2 or 3 months. Arthritis can also affect the shoulder and elbow. And though it's not as debilitating as arthritis when it affects the hip and the knee, there are occasions when the pain is so severe that replacing the joint is normally the best way forward. So shoulder replacements, though not that common, are certainly possible, and it's something which we do at the Spire Sussex reasonably regularly. Patients are normally in hospital 2 or 3 nights, and though the range of movement afterwards isn't always better, they're normally much more comfortable from the point of view of pain.